Excellent. All right. So today's topic, I think I got a little grandiose with the title. Initially is looking at randomized controlled trials and identifying some of the problems with the evidence. One of the things I really wanted to focus on was some of the issues with dosing and how that related to some of the treatment guidelines and the mismatches that we see there. Having not laid some of the foundation, I realized as I was putting that together that that's much larger than just a 15 or 20-minute presentation. So we're going to focus on some of the fundamentals and highlight some examples with the treatment guidelines. But that could definitely, I did not want to disgrace it with just a complete superficial drive-by and say that was done. So this will be kind of more of a part one. So my grand idea is that I can get this done in a short period of time. Then I put the objectives together and realized that that's not going to fit in 15 to 20 minutes. So for today, we're going to compare populations, and this is going to make a difference compared to clinical practice because I think that's what's most relevant, but also into some of the treatment guidelines. We're going to describe some of the common dosing strategies and how that differs from what we may use and why that may really limit some of its effectiveness in informing evidence-based treatment. And the last thing is to really contrast some of the efficacy endpoints that we see. I'm going to use depression as an example just because I think it's a good example, but we could really extrapolate this to any other indication and how that doesn't necessarily always align perfectly with what we want our clinical outcomes to be, which may then have some implications for what that looks like in clinical treatment guidelines. So first of all, looking at some of the population considerations. Excuse me. Apparently the allergens here are very different than back in Ohio. So populations with randomized clinical trials, they really want to control these. So you'll see quite a few that have a restricted age range. For adult populations, it may be much more robust. So maybe it's 18 to 64-year-olds. That is going to exclude some of your geriatric patients. There may be a tremendous amount of variability within that age group. The pediatric adolescent population, oftentimes that may be split. If they do use a relatively large group, an 8-year-old is very different than a 16-year-old. So trying to make them homogenous and say that it's the same, especially in the mental health realm, really is inappropriate. So most of the time they're looking at a very discrete age range for their sample population. They oftentimes will limit some of the comorbid conditions. So in the inclusion-exclusion criteria, you'll see an extensive list of conditions that individuals are not able to have, as well as other medications. Sometimes there will be medications that will automatically exclude patients. On the other side, there may be medications that are required to go alongside, and one of those may be birth control. Female adult patients may have to be on an oral contraceptive, especially with epilepsy medications, because they do not want that patient becoming pregnant. So they either have to be on the oral contraceptive or they need to have multiple forms of contraception that they're using. But that does give us some information on tolerability, as well as any other potential changes that would happen with that combination right away. So that's one rare example of where that kind of works to our advantage. They may limit the number of prior treatments that are tried. In trials for schizophrenia, it's not uncommon to say that patients could not have failed more than one or two other prior treatments. We know that patients with schizophrenia who have not responded well may be less likely to respond well. So if you have brand new antipsychotic X, you don't want to be proving its efficacy in a population that didn't respond to most of the other antipsychotic medications that we currently have available on the market. So that really would set them up for a disadvantage. So it does skew the population a little bit for a very particular slice of those patients that have that indication, be it depression, schizophrenia, or whatever. They also may specify the disease severity, and in most cases, there will be a particular threshold. I point this out because I think it's something we overlook relatively frequently. On the depression side of things, that threshold may be more moderate depression, where in clinical practice, you're not seeing patients with moderate depression. They may be coming in and complaining when they have severe symptomatology. So really making sure that we're watching that, as well as if they're excluding certain patients. So in some cases, there will be particular subsets of patients that they do not want included. So in some of the depression trials, they specifically restrict patients who may score high on some of the anxiety subscales. Some of the reasons that they may do that is because they may be researching this for an anxiety publication indication. In other cases, they want to specifically make sure they've removed individuals that have those particular tendencies. So really looking at what type. In clinical practice, you're not able to screen those patients that have an anxious, depressed severity or that may have insomnia that goes alongside of it. It's much more of an all-comers, which means that it's not really a great alignment at all times. You may have a much larger patient age range. They come in with all different types of comorbid conditions, other medications. They may come in with pharmacogenomic differences that aren't represented in the study populations, and they have all kinds of history. So just because the patient has been tried and failed on other options doesn't necessarily mean that we could say, well, that didn't fit the population, we're not going to be able to provide treatment there. So it's then trying to extrapolate what we do know to make the best decisions. Now, there are advantages and disadvantages to having those different populations. And I put this in here because I think that when we look at the differences between the clinical trial population and the clinical practice population, it seems relatively skewed. But some of the advantages to having that, I'm going to call it a cleaner population, a very specific population, is we're able to get rid of some of the confounders. So you're really able to determine whether or not an agent such as an antidepressant, an anti-anxiety medication, a sleep medication, to see if it really works or not. And that's a huge advantage. It also gives an opportunity to look at what some of the tolerability issues might be. So not having other conditions, so if a patient has depression alone with no other illnesses, then we'd be able to see, what impact does this have on other factors? So on their sleep, does it cause any changes in any of the metabolic parameters? And really get a better idea of where we need to focus as far as monitoring and education, as well as toxicity and tolerability. So it's not always a bad thing to have those very discrete populations. I think it is important that we look at diverse populations. So some of the study, and the word went completely out of my head. Some of the locations where they do the studies, the study focus areas where they're recruiting all of their patients from, those socioeconomic or demographic areas may not be representative of where you're practicing, but may be very representative of other places. So that may be able to give a much better representation of how this would work in some of those different demographics. Unfortunately, at least in the United States, we do tend to see a preponderance of Caucasian participants in randomized clinical trials, but there have been efforts to specifically recruit additional ethnic groups to try to get at more of that diversity. So beginning to see a little bit more of how these medications work in other patients. Related to that, the gender differential, trying to make sure that it's a good representation of both males and females, being that they may not necessarily respond the same way. So it can give us kind of really focused, in-depth look in some of those areas, which isn't a bad thing. And I just wanted to make sure that we did provide that balance and not just say, well, it's a clean population that doesn't reflect clinical practice. There are advantages to that. Other things with the clinical trials, so in addition to really controlling their population, we also see that they control their dosing strategies relatively closely. So the first two columns are the two dosing strategies that are used most frequently in randomized controlled trials. So the fixed dose, this tends to be something that's used early in clinical trials. It could be dose finding. So after the animal trials, here are the doses that we think that we should be using. How high do we need this to go? So for example, I'm like choking. I'm going to take a drink for a second. I apologize. For some of the antidepressants, so if we take fluoxetine, for example, it would, even though we may use between 10 and 40 or 60 milligrams, dose finding studies may start at 2.5 or 5 and go up beyond 100. And it's just trying to determine how much can a human tolerate and then which ones are most effective. It also can be a comparison between the doses. So especially with the antidepressants, we do tend to see with many of the SSRIs that there's kind of a ceiling effect. So it doesn't make sense. I'm going to use citalopram, for example. 20 milligrams of citalopram really gives you the maximum amount of efficacy. In those few patients where we used to go up to 40 milligrams, other than some select anxiety disorders, it didn't give a tremendous amount of advantage as far as efficacy for treatment of depression or anxiety symptoms. So having those dose comparisons, having everybody on just these set doses, be it 5, 10, 50, whatever those identified doses are, can be really, really telling and helps us provide a foundation. I would actually challenge that it's really beneficial to go back and look at some of those studies, because you may find, especially with antipsychotics, that the doses where we get the effect that we want may be much lower than doses that we've traditionally used in the past. So they can be very, very helpful. With the flexible doses, the trials will allow for some degree of dose adjustment. So in some cases, it's titration up to look at tolerability or to try to get additional efficacy. In other cases, it may be where we want you on a particular dose for a certain period of time, and then we're going to ask to reduce it to see if that efficacy maintains or if we see differences in the adverse effect profile. It allows for some degree of change, but it's not a complete change. So it tends to be in fixed dose increments. So if you can't tolerate 20, we can drop you to 15. If you can't tolerate 15, we'll drop you to 10. But it's very set increments that are there. You're not just allowed to be able to do a 17.5 or something different. I'm going to contrast this with clinical practice, where we may see any dose and any frequency. So instead of taking 200 milligrams of sertraline, it may be 200 milligrams of sertraline one day and 150 another day. It may be back and forth just based on what a patient has going on. So we may see a whole lot more variability within clinical practice. And I would say that the dosing strategies can inform the decision. They really lay the foundation to be able to say, here's what we would expect, but then we need to tailor it for each of our individual patients. And what we see also to bring in the clinical treatment guidelines is you tend to get that big range. So I'll use the antipsychotics, for example. So you may see a range of 2 milligrams of risperidone to 8 milligrams of risperidone, or in some cases 10 milligrams of risperidone, when we really probably don't need to use doses that are that high. So 1 to 4 milligrams may be plenty for many of those patients. So oftentimes when they have the fixed dose or flexible dose, those anchor points are the ones that are used because we have evidence to support that, but that may not always reflect the best decisions for clinical practice. to bring it full circle, so who we study it in, how we dose it, and then what we're evaluating as far as efficacy. The ultimate goal is really that improved clinical picture, so that the patient is getting better, that their symptoms are resolved, that they're really not suffering anymore from whatever condition it is that we're treating. And we see a few different ways that and that would be the goal for clinical practice. And I put that at the top because ultimately that is the goal. For the trials that we see, we oftentimes see rating scale scores, quality of life scores, as well as retention to treatment. And we're going to talk about each one just a little bit here. So looking at some of the rating scale scores, I'm going to focus on depression just because I think it's most individuals have seen depression, antidepressant trials, and I think it's a really, I use it as an example. It's a familiar example for me to highlight some of these differences. So you can have clinician rating scales. So if they're using a Hamilton Depression Rating Scale, so the HAM-D, it's rated by the physician, mostly researchers, not done in clinical practice. It takes quite a while. But how much of a reflection are we? It's not something that tends to be done generally in clinical practice. That isn't thought to be a good use of that time that you have face-to-face with the patient. There are patient-scaled rating scales. So the Beck Depression Inventory, the PHQ, and in cases like this, you're getting information from the patient that you could use real time. So some of those may be very applicable to your clinical practice where you're able to see, okay, we can follow these score changes over time. In the trials themselves, there's different ways that they look at efficacy. So it could be change from baseline. So where the patient started, how much did their score change? In some cases, if it's a short trial, they're just looking for initial response. Did the symptoms get better? That does not always mean that the patient is better. So just because their Hamilton D score dropped from 27 to 24, statistically, if you have enough people, that could be a statistically significant response in the drug group. But clinically, that may not mean that that patient is doing any better. They still have a significant number of symptoms. They still would be classified as being moderately depressed. So we really want to think about what scores they're using and what those endpoints or those cutoffs for true efficacy are. In some cases, they just look at the score change over time from baseline to endpoint. How much did it change? And again, that's not getting always to the true patient outcome. So the patient's better, but if they still have a significant number of symptoms, then that's not really the clinical outcome. So we're saying in the literature, this is effective for the treatment of depression, but the patient's still depressed. They're not in remission. They haven't achieved a full recovery. And that can get expensive. That can get expensive for the clinical trials. And that's not always well represented in the treatment guidelines. It'll show this did work. So it was considered effective for the treatment of depression. And you can continue for at least a year. Okay, well, what happens at that year time frame? You know, we may not be cutting patients off of their antidepressant at that time point. We may want them to continue on it. And in many cases, we now have patients who have a burnout effect. So who would those be? How do we identify them? How are we able to capture that and be able to measure for it? And that's not well reflected in any of the clinical trials and really would be expensive for the drug companies to do. And since most are generic, that's not something they're necessarily going to look into. So recognizing that we may have smaller snapshots that'll tell us how effective things are, but not necessarily long-term. The other two are a little bit more patient-focused, so they're closer to our target, which is why I put the bullseye there. With the retention to treatment, this tends to be a secondary outcome for a number of our clinical trials. So how long did patients continue to take their medication? How long did we keep them in treatment? This has come out as more pronounced outcome than what it used to be. It used to be very focused on those rating scale scores. this is actually more reflective of clinical practice. So are they going to stay on treatment? Is it something that's effective for them? If they don't stay on, why are they stopping? If it's they're using an antidepressant for anxiety and they stop within the first 2 to 3 weeks because they think it's not effective, that's really helpful to know that we need a check-in point to be able to encourage patients to keep taking it. No, you probably don't see anything right now, but you need to keep taking this medication, because then after you've been on it for a while, that's when we'll be able to see how effective it is. Also tolerability. If there are adverse effects that may occur, how can we support those patients over time to be able to see that, you know what, in the first couple weeks, these side effects are really rough. But if you can get through those first couple weeks, then things get much, much better and your body gets used to it and you won't experience those same side effects. That can be really powerful education on the clinical practice side to be able to provide that. So that may be incredibly relevant there. Not always included as an endpoint for incorporation into the treatment guidelines, at least not yet. On the flip side, though, in the trials, oftentimes patients do have some incentive, so they may be paid for their participation. So they kind of have an external influencer that would encourage their continued participation, because then they get paid, when maybe out in clinical practice that wouldn't be happening. So it's not always just a perfect match. One of the last items that does show up, although it tends to be a secondary outcome, is looking at quality of life. So this could be done by a standardized quality of life rating scale, but it really helps identify whether or not, you know what, did that small reduction in symptoms actually result in improved quality of life. So if you have a new mom that's incredibly depressed and doesn't have a lot of energy and isn't sleeping much, but really is so fatigued they're not able to care for themselves or for their infant, if we make a small change numerically on those symptoms, we may see a big change in the quality of life score. So technically, there may not be a huge scale, rating scale difference, but that was what they needed to be able to take care of other activities and maybe feel more fulfilled that they're able to align their goal of taking care of their newborn with the fact that maybe they have a little bit more energy and they're willing to be okay with that, even if they do have other residual symptoms. So I think that tends to be an underestimated endpoint that's much more closely aligned with what most of our providers are doing in clinical practice. So it definitely better aligns with it. It's, again, not a perfect alignment, but something else that we can look at where maybe that efficacy finding isn't super robust, but it seems to be getting at some of those really problematic symptoms that are helping patients feel that their quality of life is much better. So the clinical trials, so it's a piece of the puzzle. I was looking for I couldn't find one that was in the public domain, but a foundation. So these are the building blocks for having the evidence-based medicine, but they're not going to be completely applicable to your patient populations. What I will encourage is you each have a really unique clinical practice, and you come across situations where you're using a medication in a different way, whether it's one of the new long-acting injectable preparations that's been used at a different dosing schedule. I'm looking at you, Dr. Ballister. That's helpful to get out into the general literature so that we're able to continue to build on that so people can see additional experience with some of those medications. So the evidence is part of the puzzle, but your clinical expertise definitely still plays a role. So at that point, I will apologize for the extraneous noise. There's all kinds of stuff going on here in the background, so I'm sorry if that was distracting.